Fibroids are the most common pelvic tumor seen in women. 70 to 80% of women by age 50 have fibroids, and it's a significant issue for African American women, 3 times more likely than their Caucasian counterparts. Approximately 30 million women in the United States have fibroids, some of whom are asymptomatic. And there's another group of women that have significant symptoms, but they don't seek out treatment. We call them the silent sufferers, probably 1 million women in the United States right now, most of whom don't want surgery, but don't know of any other option like UFE. And that's why this talk and other talks about UFE and getting the word out is so important. It's the most common reason why women have heavy periods. It's also, unfortunately, the most common reason why women undergo hysterectomy in this country, and the average age is less than 40, and that's tragic. Fibroids are classified by location. This is the FIGO classification, going from 0, which is an intracavitary fibroid on a stalk, to a 7, which is a subserosal fibroid on a stalk, and everything in between. The intramurals are the most common. Submucosals tend to cause the heavy bleeding. The subserosals tend to cause the bulk-related symptoms we'll talk about. And intramurals can do either or both, depending on which way they grow. While fibroids are the most common reason why women have heavy bleeding, that we want to remember that there are other causes, and the mnemonic PALM coin is used. PALM being the structural causes of bleeding, fibroids #1 by far, but there are others, and coin to signify the non-structural causes, which are much less frequent. Well, in somebody that doesn't have any symptoms, there's really no role for interventional radiology treatment and UFE. But there are a number of women that struggle significantly with symptoms, the most common of which we call the big 3, which is heavy bleeding, pelvic pain, and increased urinary frequency. But there are other symptoms like constipation or dyspareunia that can also affect these women. Again, fibroids are the #1 reason why women have heavy periods, and sometimes women don't appreciate the fact that it's heavy because they've been doing it for so long. A lot of these women are bleeding more than 7 days. It's either heavy or prolonged or both. And as I mentioned, sometimes they're not aware that what they're doing is abnormal. The published abnormal amount of bleeding is 80 cc's or 5 tablespoons. But again, this is something very difficult to quantify. Nobody is taking their pads and wringing them out into a graduated cylinder to see if it's abnormal. But if you're changing pads more frequently than every 3 hours or more than 8 in a day, or you have to double up, or you see clots bigger than a quarter or accidents in blood, all these things are too heavy. In my opinion, if it affects your quality of life, no matter what your hemoglobin is, it's too heavy. The clinical signs of being anemic: you're tired, you're weak, you might get lightheaded or dizzy. Your heart has to work harder, so you'll get palpitations. You might be short of breath. Migraine-like headaches are very common. These women often chew and crave ice and think I'm clairvoyant when I ask them about this. In Georgia, they can chew other things like the Georgia white clay or cornstarch. They may have hair or nail changes. And the medical treatment for fibroids is not very good. First-line therapy is often nonsteroidal anti-inflammatories, particularly tranexamic acid, which works okay. Some of these women are placed on hormonal therapy. And while we don't know where fibroids come from, clearly they grow with hormones, particularly estrogen. So this can work for a little while and lighten flow, but eventually the growth of the fibroids overwhelms the ability for a lot of the hormonal therapies to work. And then they go into the surgical therapy, or in a moment, I'll talk about the interventional therapy. But hysterectomy is obviously one of the surgical choices. If they're not interested in fertility, they'll often get told to have a hysterectomy. And while that does end their fibroid issues because there's no uterus, why are we doing this for benign disease? Vaginal hysterectomy is preferred, but it is rarely, certainly any of the patients I see, none of them qualify for vaginal hysterectomy due to the size of their uterus and the size of these fibroids. Less invasive surgical options include laparoscopic or robotic hysterectomy. Again, there are some issues with morcellating to get the uterus out. And while there's all these special ways to handle robotically or laparoscopically, open is still by far the most frequent type of hysterectomy, surgically open hysterectomy versus the less invasive ones. Regardless of whether it's laparoscopic or open, these are typically done in the hospital. There's a fairly significant complication rate, a long recovery, and importantly, and often underappreciated, you lose your uterus. And losing one's uterus has consequences. And the uterus has more important functions to women than just bearing them children. And losing it can affect them psychologically. It affects women sexually. There's a lot of bone loss after hysterectomy. And now there's good evidence for cardiovascular effects post-hysterectomy. And again, remember, these are young women, average age, late 30s. And I've seen, unfortunately, way too many women in my career in their late 20s have already had a hysterectomy. Not that they wanted it, but they weren't told of any other option. There's myomectomy for those that are interested in fertility, but it tends to be a local solution for a global problem because they typically never get all the fibroids out. And there's an 11% per year rate of recurrence. And so by 5 years, the majority of these women have their symptoms back. And then again, they're offered another myomectomy if they're interested in fertility, or if they're not interested in fertility, they're often offered hysterectomy, again, without mentioning UFE. All of these myomectomy patients are consented for hysterectomy because some of them intraoperatively will convert. And if they get pregnant after a myomectomy, typically it's going to require more surgery, a C-section. They typically will not allow them to have a vaginal birth. Well, what about UFE and the non-surgical approach to this? It's completely non-surgical. It's outpatient. I do it in the office. Compared to surgery, it's safer. It's less invasive. It's much less expensive, particularly doing it in an OBL setting versus a hospital. There's a much shorter recovery, about 5 to 7 days. I've never transfused anyone. We do Jehovah's Witnesses that can't be done surgically. And 100% of our patients keep their uterus, even have children after. And typically the births are vaginal and full term. It treats all of the fibroids, not some of them. So the recurrence rate, unlike myomectomy, is very low. There's 2 ways to get into the body most commonly to do UFE, either the right femoral approach or the left radial approach. A tiny catheter is steered into each uterine artery one at a time, and embolic particles sized for the perifibroid plexus are instilled and flow directed into the fibroids to cut off the blood flow to every fibroid in the uterus. The big trunk, the main branches of the uterus stay open. So the uterus is alive, but all the fibroids die, usually within 24 hours. It has a very high success rate. There's very low complication rate, not only in terms of numbers, but also severity. This is just 2 schematic pictures showing a right femoral approach, and they're showing a catheter. In this instance, in the left uterine artery, have some fibroids in the uterus, and then a kind of a magnification view showing these particles entering the perifibroid plexus, which are encircle each of the fibroids. This is a picture from an actual case, and you can see there's a delivery catheter, a standard catheter in the left common iliac, and then a microcatheter in the left uterine artery. And then you can see with injection of contrast, you don't see the fibroids exactly per se, but you can kind of tell there are circular balls with the vessels at the periphery of each of the balls. Each of them are fibroids, and then this is a single picture after the embolic is given. And if you continued out the run, you'd see a very slow, choppy forward flow, but none of those fibroid vessels opacify any longer. And the same thing on the other side. You can see the fibroids kind of in relief here, and then a post-embolization angiographic picture. Here's some MRI. We get MRIs in everyone. It's much more accurate than ultrasound that's done typically in the gynecologist's office. We also pick up and diagnose a lot of unknown adenomyosis, which is almost universally missed. But you can see here's an axial transverse picture, pre-embolization, showing a large dominant fibroid centrally. She had horrible menorrhagia. And 6 months later, you can barely see this fibroid. All of her symptoms are gone. She's transformed. She's a new woman. Here's another woman, again, very large dominant fibroid, and you can barely see this 6 months later. There are some risks in undergoing any procedure, but the risks in undergoing UFE pale in comparison to surgery, not only in terms of frequency, but in terms of significance. There are some women that do not menstruate ever again. However, in the over 25 years and over 10,000 UFEs that I've personally performed, I have never seen anyone under the age of 40 where that ever happened. Overall, it's about a 2% rate in all comers. And frankly, most of the women I see start laughing when I say that's a risk, so they would like nothing better than to not have a horrible menstrual that their whole life revolves around. There's a rare chance of an infection, usually responds to antibiotics. About 5% of women will temporarily pass some fibroid material vaginally. We've had a very small number of women need an actual hysteroscopic removal of these fibroids that have aborted but aren't coming out, if you will. The patient isn't able to pass it. There is a transient hypercoagulability for undergoing UFE, so there is a very small risk of a DVT or occasionally, rarely, a PE. It's very low and much lower than surgery. Usually the people that get a DVT post-embolization have multiple risk factors, including being obese, being on birth control, et cetera. You could have some local complication, again, very unlikely and trivial, a hematoma, or in a very rare case, pseudoaneurysm of the artery. So again, the fibroids are all treated. It's very effective, has a 90% success rate, and it's durable, unlike myomectomy. You spare the risks and long recovery of surgery. It's an outpatient procedure. Our patients go home with a Band-Aid several hours after the 30-minute procedure. It allows women to keep their uterus, which is, again, often underappreciated, even have children. And this has been endorsed with the highest level of medical evidence by the American College of Obstetrics and Gynecologists. It's just the rank and file often fail to mention this, and UFE is covered by all insurance. So in conclusion, UFE delivers outstanding results for women suffering with symptomatic fibroids. It should replace UFE as a frontline option. Certainly every woman is entitled to know all the options, including UFE. Unfortunately, that's typically not done. Just the surgical options are given. And compared to surgery, again, UFE is much safer. It's much less invasive. The recovery is much shorter. It's less expensive. And again, you get to keep your uterus and even have children afterwards. Thank you.